Welcome and thank you for joining us for today's presentation. I am Lisette Gutierrez, coordinator at the UT Health Houston Institute for Implementation Science. This event is part of the UT Health Houston Institute of Implementation Science seminar series, which features lectures by leading experts in the field of implementation science. Registration for upcoming seminars and recordings from past events can be found on our website. We have a few quick announcements before we get started. The seminar is being recorded and the recording will be posted on our website after the event. All microphones are muted. If you have any questions or comments during the presentation, please enter them in the Q&A box as there will be time for questions after the presentation. We are pleased to offer one entry-level CHESS MCHESS credit for today's seminar in collaboration with the Michael and Susan Dell Center for Healthy Living, housed at the UT Health Houston School of Public Health in Austin. The Michael and Susan Dell Center for Healthy Living is a designated provider of continuing education contact hours for certified health education specialists and master certified health education specialists through the National Commission for Health Education Credentialing. If you requested CHESS or MCHESS credits, you will receive an email within 1 week following the webinar to complete your evaluation. Please keep an eye on your inbox for this. We would like to give a big thank you to our Institute for Implementation Science members for attending today's event. Our members receive perks such as access to our networking events, educational opportunities, and the opportunity to speak at our seminars. If you are interested in becoming a member of the Institute for Implementation Science, please visit our website for more information. Now, I would like to introduce the UT Health Houston's Institute for Implementation Science co-director, Dr. Maria Fernandez, to introduce today's speaker. Thank you.
Thank you, Lizette. Hi, everybody. I'm Maria Fernandez, Vice President of Population Health and Implementation Science at UT Health Houston and co-director of our Institute for Implementation Science. And I'm actually going to pass it over to co-director Dr. Bijal Bala for the introduction. But I wanted to say how excited I am about today's speaker. We have a long-standing collaboration through the Cancer Prevention Control Research Network for many years. And she's a phenomenal implementation scientist. So turning it over to you, Bijal, for the introduction.
Thanks, Maria. Yeah, no, I want to share the excitement for having you here, Dr. Leeman. Dr. Leeman is a distinguished professor in the School of Nursing at the University of North Carolina at Chapel Hill. She's an implementation scientist with extensive experience applying mixed methods approaches to tailor and test multi-level implementation strategies. She co-led studies to scale up the Med-South Healthy Lifestyle Program in health departments and federally qualified health centers, and serves as the implementation lead on studies to implement interventions in a wide range of other settings, including primary care clinics, skilled nursing facilities, nurse home visitor programs, and rural emergency departments. So important in implementation science to have that range of context and contextual factors to study from. So really excited to hear about this very important topic on scaling up complex interventions and to really learn from these lessons from 3 studies that Dr. Leeman, you'll be presenting on. So with that, I will hand it over to you, and thank you so much.
Well, thank you for inviting me. This is an honor for me to have this opportunity to present my work. I'm going to start by acknowledging the funding for the 3 studies that I will be talking through today. That includes the National Heart, Lung, and Blood Institute, the Harry and Jeanette Weinberg Foundation, and the Rita and Alex Hillman Foundation. I'm going to start very briefly with the challenge and an introduction to the framework that will guide this presentation, and then spend most of my time on 3 lessons with illustrations from our research, and then end with some future directions for the field. So starting with the challenge. As all of us are aware, we have a growing menu of effective interventions, and many of those interventions address our most pressing health problems: chronic disease, mental health conditions, unhealthy lifestyle behaviors. Many of these interventions are complex, particularly those interventions that address these most pressing health problems. And scaling up complex interventions is challenging. The interventions themselves are complex, involving multiple components, multiple disciplines who often interact over an extended period of time. The implementation context also is complex, and the intervention and context interact in ways that are hard to predict. Complexity science provides guidance for scaling up complex interventions, and Lanham and colleagues in 2013 wrote an article that described the way that complexity science could guide scale up of complex interventions, and highlighted 3 things that local teams need to be supported to do when they are trying to implement complex interventions, including those local teams need to engage diverse perspectives, promote local sense-making, and self-organize to align implementation with their context. So the question is, how do we design scale-up initiatives to support these goals? And that's one of the things that I'm going to be addressing as I present my 3 lessons. So moving on to the framework guiding this presentation and starting with the definition of scale-up. I like this definition from Ben Sharif and colleagues as scale-up as a systematic approach used to roll a successful intervention out at the regional or national level. The framework that will guide this presentation is Barker and colleagues' framework for going to full scale, which describes scale-up planning as a multi-phase process. There are 4 phases, and those phases are influenced by factors at the level of adoption mechanisms and support systems. As I go through each of my lessons, I will walk through each of those phases and focus primarily on the role of support systems. At the end of the presentation, I will present suggestions for future research to further build out the adoption mechanisms component of this framework. So, my research, which you've already heard some about in the introduction, for over 2 decades, I have collaborated with intervention researchers to develop, implement, and scale up their interventions. And these are the researchers that are or have led the 3 studies that I'm going to be talking about. So my first lesson is the need to specify 2 levels of implementation strategies. Much of my work on scale-up builds on Wandersman and colleagues' interactive systems framework for dissemination and implementation. Wandersman contends that the delivery system is those systems and settings that adopt and implement interventions, which includes hospitals, community clinics, schools, health departments, and others. Many delivery systems lack the capacity to adopt and implement new interventions, particularly the complex interventions that are needed to address our most pressing health problems. For that reason, we also need support systems that provide training, resources, and other supports to build delivery system capacity. Often, this is initially the research team. However, to sustain scale up over time, more established support systems also need to be involved, which may include government and nonprofit organizations or centralized offices of healthcare systems, among others. Consistent with 2 levels of systems, there also are at least 2 levels of implementation strategies that you need to think about. At the delivery system, this includes the strategies that delivery systems need to engage in sense-making and self-organization to align implementation with their local context. It also includes the support systems strategies used to build delivery system capacity. So my illustration for this lesson comes from the Connect Home Transitional Care Intervention, which is led by Mark Tolles. The problem this intervention addresses is that each year in the US, 1.6 million older adults transfer from hospital to a skilled nursing facility for a short stay, often for rehabilitation, and then they transfer to home. Their outcomes following the transfer to home are not good. One study found that within 90 days, over 50% had died, used emergency services, or been rehospitalized. The intervention is Connect Home, which prepares older adults and their caregivers for the transition to home. The delivery system is the skilled nursing facilities, or SNFs. And in this case, the support system is the research team working in partnership with Lutheran Services of America. Just a little bit more about the Connect Home Transitional Care Intervention. In step 1, staff in the SNF initiate a transition plan of care. In step 2, they convene a care plan meeting. In step 3, they prepare the patient and their caregiver for discharge. And in step 4, they call the patient and caregiver at home to follow up on the care plan. So this is a complex intervention that with multiple components involving multiple disciplines over an extended period of time. So now going back to our framework, I'm going to walk through each of those. Well, I'm going to walk through the first 3 phases for this intervention and talk about support systems. So scale up phase 1 involves the initial setup of the planning for scale up. And one central component of that setup is engaging partners. And in this case, it involved engaging partners from the skilled nursing facilities and all the representatives from all the disciplines involved in planning for discharge were engaged in the design and planning for scale up. And then also representatives from the support system, Lutheran Services of America. And this was first piloted by Lutheran Services Carolina, and based on the success of that pilot, that provided entree to Lutheran Services of America. Phase 2 is develop the scalable unit. The scalable unit is the thing being scaled up, also referred to at times as a change package. The scalable unit includes the intervention, in this case, Connect Home, and implementation strategies at the level of both the delivery system and the support system. So continuing on with phase 2, at the delivery system level, strategies included identifying champions within the skilled nursing facilities, having them organize an implementation team, having those teams conduct cyclical small tests of change, and making changes to the record system. At the level of the support system, strategies used to build the capacity of the skilled nursing facilities included creating a learning collaborative that brought together representatives from each of the involved SNFs, conducting on-site training within the SNFs, and providing virtual facilitation or coaching to each of the implementation teams within the SNFs. Scale up phase 3 involves testing the scalable unit, and this was done over 3 feasibility studies. And I'm going to give you the outcomes from the second of those feasibility studies. First, the framework we use to evaluate Connect Home Scale Up. You can see to the left, we have the intervention. Then we have the 2 levels of implementation strategies at the level of the skilled nursing facility and Lutheran Services. Then we have 2 levels of implementation outcomes. And so at the level of Lutheran Services, at the bottom there, we were interested in whether the capacity building strategies reached staff in the skilled nursing facility and were acceptable to them. And then at the level of the skilled nursing facility, reach to patients, fidelity to the implementation strategies and the intervention, and was it acceptable? I'm going to present just some of the findings from this study, starting with implementation outcomes at the level of the support system. And so this is findings on reach to SNF staff. The 2 learning collaborative meetings had excellent reach, as did the 4-hour on-site training. The monthly virtual facilitation to the implementation teams was mixed. It was good into SNFs and not so good in the other 2. Moving on to implementation outcomes at the level of the delivery system, and in this case, fidelity to those implementation strategies. Site champions had excellent fidelity. Implementation teams were mixed. All 4 SNFs created teams, but the teams did not meet regularly, and their conduct of small cyclical tests of change was poor. Continuing with implementation outcomes at the level of the delivery system, and this is intervention fidelity, and this is the number of patients. In this case, it was the 325 patients who were reached by the intervention. What proportion of them received each of the components of the intervention? So to the left, you see the core components of Connect Home. And what you may not be able to see is that this graph starts at 78%. So intervention fidelity was very good for this. So if intervention fidelity was so good, why do we care that implementation fidelity in the SNFs was mixed? So the SNFs achieved that good level of intervention fidelity during active implementation, when both the research team and leadership from Lutheran Services were actively involved. To sustain that fidelity, the SNF staff need to have self-organize, monitor, and maintain implementation. In other words, they need to have functioning implementation teams who are able to conduct small cyclical tests of change when they need to make improvements over time to adjust to changes in the SNF. So to sustain fidelity, delivery systems need to achieve both implementation and intervention fidelity. So just to summarize from lesson 1, to implement complex interventions, specify 2 levels of implementation strategies. Delivery system strategies provide explicit guidance on the actions required to engage diverse perspectives, promote sense-making, and self-organize implementation to fit the local context. Support system strategies provide explicit guidance on actions required to build delivery system capacity. So these are 2 recommended readings on this idea of 2 levels of implementation strategies. I will tell you that at the end of this presentation, I have a QR code that provides a link to all the citations in the presentation. So lesson 2, start with your practice partners' change methods. So as we are all well aware, we could not do implementation science without engaged practice partners. Our engaged practice partners are essential to co-designing interventions and implementation strategies. They are the ones that actually implement and sustain the intervention, and they work with us to assess implementation outcomes. The challenge is there is a persistent gap between implementation science and practice. Implementation science has developed many models, frameworks, and methods with distinct and often complex terminology. At the same time, our practice partners have expertise with their own models and methods, often drawing from quality improvement. When we, as implementation researchers, impose our methods on practice partners, we risk promoting scientific imperialism. That quotation comes from a critique of implementation science by Miller and colleagues. They go on to say that to bridge the gap, we need to alter the power dynamic and re-empower practices by shifting the emphasis regarding the source and direction of change from outside in to inside out. One way of doing this is, rather than coming in with our list of implementation strategies, instead begin by understanding the methods that our practice partners are already using to make change, and then work from the inside out. My illustration for this lesson comes from a study on advancing care for childbirth-related hypertension that's led by Kate Bernard. The problem this addresses is that 84% of pregnancy-related deaths in the US are preventable, and hypertensive disorders of pregnancy are a major contributor. The intervention is a safety bundle with evidence-based guidelines for recognition and response to severe hypertension during pregnancy and postpartum. The delivery system is health departments and community clinics serving predominantly low-income women. The support system at this point is largely the research team. We are in the middle of this study, and we are working on building connections with more established support systems. In scale-up phase 1, we organized a coalition which has been with us through planning, designing, pilot testing, and now rolling out the intervention. It includes clinic providers and staff, patients, and representatives of community organizations. We also created 2 patient work groups that include women with lived experience with severe hypertension during pregnancy. To develop, in phase 2, develop the scalable unit. The intervention, again, is a set of guidelines that are part of a safety bundle. The implementation strategies, in this case, are at the level of the delivery and support system, and I'm going to focus primarily on talking about how we developed our implementation strategies. And we did so by starting with our practice partners' preferred approach to change. So we learned from our work with our coalition that the clinics we were working with were familiar with and had experience with the Institute for Healthcare Improvement's model for improvement. That model includes a number of different methods, central to which is the Plan, Do, Study, Act cycle. So we selected implementation strategies that built on our partners' change methods. So with the delivery system, we created quality improvement teams, and we had those teams work through Plan, Do, Study, Act cycles. At the level of the support system, we had a quality improvement coaches work with the quality improvement teams. And so we hired 2 full-time nurses to serve in the role of quality improvement coaches. We did lunch and learn lessons, or are doing lunch and learn lessons in the clinics to provide training on the guidelines, and we provided educational materials. All of those methods align with methods in the ERIC Compendium of Implementation Strategies. The important point is we did not start with ERIC. We started with the clinics in methods, and we use the language of the clinic. We selected an additional strategy to overcome a critical barrier, which is the fact that severe hypertension during pregnancy is a rare event in most outpatient settings. And so while it has severe consequences, it's not highly common, and the care teams didn't have an opportunity to practice and apply what they learned. And so we did simulations of severe hypertension using patient actors with the care teams in the clinics. So having selected our implementation strategies, we then tailored them. And at the level of the delivery system, we tailored the strategies to the processes clinics would need to engage in to implement the hypertension bundle. And so, for example, the QI teams needed to adapt and implement a protocol for blood pressure monitoring. adapt and implement an algorithm for clinic response to severe hypertension, review and update their patient education materials, develop a plan for orienting new staff, etc. We then tailored support system strategies to build clinic capacity to engage in those processes. And I'll just start with the first example here. The QI coaching that was provided, we developed a detailed protocol so that the QI coaches could progressively coach the QI teams through each of the processes those teams would need to engage in and test out with plan, do, study, act cycles in order to integrate the guidelines into practice in their clinics. Scale up phase 3, test the scalable unit. We are in the midst of doing this for this study. We are conducting a hybrid type 3 effectiveness implementation trial in 19 clinics, and we are assessing engagement outcomes, effectiveness outcomes, and implementation outcomes, including fidelity to both the delivery system strategies and the support system strategies. And the protocol for that paper, the citation is there, and will be in the list provided at the end. So lesson 2, building on partners' methods empowers practices. It leverages existing expertise and experience. It promotes local ownership, and it strengthens methods partners will need to monitor and iteratively adapt the intervention to fit an ever-changing environment. Again, I have some recommended readings from our work where we've on this approach. Lesson 3, build implementation strategies into support system infrastructure. Again, our framework. This time we're going to walk through all 4 phases of Barker's framework with a focus on support systems. So the challenge here is sustaining scale up beyond the end of research funding. After funding ends, resources are lacking to support efforts to sustain the intervention or to spread the intervention to new settings. One solution is to build implementation strategies into support system infrastructure. The definition of infrastructure here is organizational and workforce support systems required for implementation at scale. Some examples of infrastructure include communication systems, online management systems, the existing workforce, and data monitoring systems. The illustration for this lesson comes from the Mental Health Innovation for New Mothers, which was led by Linda Bieber. The problem that this intervention addresses is that up to half of low-income mothers experience some symptoms of depression and anxiety. This is a concern for the well-being of the mothers. It's also a concern for the well-being and development of their young children. The intervention in this case is generalist nurses, so nurses that do not have training in mental health, provide depression and anxiety screenings, brief interventions, and referral to mental health providers during home visits to new mothers. The delivery system in this case is the visiting nurse agency. The support system is the nurse-family partnership. Starting with scale-up phase 1 setup, Dr. Bieber engaged a planning group that met at least monthly for a few years with representatives from the delivery system, in this case, nurses from agencies that provide home visiting services for new mothers, and from the support system, national and regional leadership within the nurse-family partnership. To develop the scalable unit, phase 2, I'm going to focus on the work the planning group did to assess existing infrastructure, tailor implementation strategies, and build strategies into support system infrastructure. So continuing with phase 2, this is the infrastructure of the nurse-family partnership. There's a national service office that includes a clinical data system, an education system, and a practice integration system. Within the education system, there's a repository of online training modules, and there's a repository of team meeting education modules. Within the practice integration system, there's online clinical resources and a team of nurse consultants. And this infrastructure supports over 250 local agencies. So with that infrastructure in mind, we tailored implementation strategies. This included developing 5 online training modules to build nurses' knowledge, skills, and confidence to address new mothers' mental health symptoms. It included 6 team meeting modules that nurse supervisors in the local agencies could use in their team meetings to reinforce and practice the new skills being learned in the training modules. It also included 11 clinical resources for nurses to use directly with mothers. For example, a crisis management decision aid, a suicide risk assessment, and mindfulness activities, among others. The final was adding 2 nurse consultants to the NFP's team of nurse consultants. And these were 2 members of our research team with expertise in mental health. And we invited a subset of the agencies to send teams to 6 interactive webinar discussions to work through case studies and problem-solve challenges. So the first 3 of these were part of standard implementation, and then a subset of the teams got enhanced implementation that also included the nurse consultants. So we built these strategies into the infrastructure, and you can see with the orange where this was built into the existing infrastructure. In phase 3, the Nurse Family Partnership implemented this nationwide, and we compared standard versus enhanced implementation. On implementation outcomes and effectiveness outcomes, citations to findings from this study are provided. I'm going to just give a few of the implementation outcomes. So REACH, the rollout reached 264 agencies across 40 states, serving over 50,000 women. Adoption, we looked at adoption at the level of the nurses. We were able to pull data on adoption of online modules from the Nurse Family Partnerships data system, and 60 to 76% of nurses completed each of the online modules. For the team meeting modules, we surveyed nurse supervisors, and so those supervisors that responded, 27 to 51% reported using each module. For the nurse consultants, of the 110 teams invited to participate, 45 participated in at least 1 meeting, and 33 of those attended all 6 sessions. So this has gone to full scale, or most of the components of this scale up have gone to full scale. The Nurse Family Partnership is sustaining nationwide scale up of the online training modules, the meeting modules, and the clinical resources. So this illustration is a best case scenario. Rarely have I been part of a project that had the opportunity to engage a national support system at the start of scale-up planning. And I really wrestled with whether to do this illustration or to provide an illustration of a study that we just finished up, where we started to really plan for a transition to an established support systems infrastructure much later in our scale-up planning. But the principles are very similar. And so even if you start towards the end of planning, you still want to walk through the same steps. So lesson 3 summary: support system infrastructure is key to sustaining scale-up. Sustaining scale-up is challenging. New interventions take priority over the old. Staff leave and new staff are hired. So plan early to transfer implementation strategies from the research team to an established support system. Build strategies into the support system's existing infrastructure. So this is an overview of the 3 lessons. First was specify 2 levels of implementation strategies. Second, start with your practice partners' change methods. Third, build strategies into support system infrastructure. And in going through these, we've walked through the 4 phases and talked about support systems. We have not talked much about adoption mechanisms, which takes me to the final phase of my presentation, which is talking about priority areas for further research with a focus on adoption mechanisms. So Barker broadly defines this as the environment for change and psychology of change. Scale up is about change, gaining adoption across settings and systems. And so the outer setting or outer context is key to adoption. What does it take in the environment to get settings to adopt new interventions? He describes several potential adoption mechanisms. This includes communication, social networks, a culture of urgency and persistence, leadership, and policy. So priority areas to address these adoption mechanisms, I'm going to talk about the need for a greater focus on dissemination research, on vertical scale-up, and on organizational theory. So starting with dissemination research. This dissemination research is essential to promoting wide-scale adoption. However, the field of dissemination research has not coalesced to the same degree as implementation science. And that's a quotation from Bauman and colleagues. Definitions of dissemination research are inconsistent. At times, dissemination is, in fact, used as a synonym for scale-up. Efforts to identify and test dissemination determinant strategies and outcomes have been limited. To promote wide-scale adoption across settings and systems, dissemination research is needed on how to customize communication for different audiences. Messages, formats, and distribution channels all need to be considered, and how to engage social networks as a key mechanism driving adoption. So priority number 2 is organizational theory. And here I'm talking about the theories that describe and hypothesize how organizations themselves behave within the wider environment. Organizational theories are important because they provide multiple constructs and propositions to guide research on the environment for change, including the psychology of change. Some of the theories that might be drawn on include resource dependency theory, contingency theory, institutional theory, transaction cost economics. I want to call out the work of the Cancer Prevention and Control Research Network that Maria mentioned right at the beginning of this presentation as an area where she and I have collaborated for a number of years. CPCRN has done work on organizational theory and has a work group that has developed one-pagers that describe different organizational theories for implementation science and provide lists of constructs and propositions and citations and beginning thoughts on how they might be applied in implementation science. So if you go to the CPCRN website, and I have the URL there, and click on resources, you'll get this screen, which will let you click on that resource. Priority number 3 is vertical scale-up. So most of what I've been talking about in this presentation is horizontal scaling up, which the ExpandNet describes as expansion, replication, and spread of an intervention across settings. To achieve really robust and sustainable scale up, it's important to also consider vertical scaling up, which is defined as supporting intervention scale up through changes to policy, political, legal, budgetary, or other health systems change. Research on vertical scale up has been much more limited than on horizontal scale up. A recent review of experimentally tested implementation strategies found the following ERIC strategies were not represented in any of the studies. And if you look at that list of strategies, all of them may be conceptualized as for use in vertical scale up, changing policy to create an environment that's more supportive of an intervention scale up. Vertical scale up is more common in low and middle income countries versus high income countries. And this was one review of scale up studies, which found you looked at policymaking and resource mobilization strategies and found that they were much more commonly used in studies in low and middle income countries than those scale up studies in high income countries. The challenge for high-income countries, or at least the United States, is the scale-up of a research-tested intervention necessarily involves its insertion into a bureaucratic machine of substantial proportions. The day-to-day functioning of the health system and of the national health bureaucracy is therefore a strategic variable. So we are faced with a challenge in our efforts to do research on vertical scale up, but I would suggest it's worth doing what we can to meet that challenge so that we can work towards more sustainable scale up of our interventions regionally and nationally. So that is my presentation. Thank you. And I have my email address there, and I also have the QR code that provides a link to the citations from this presentation.
Excellent, excellent presentation, Jennifer. So I have a couple questions here, and please, just as a reminder, if you have questions down at the bottom, you can see there's a Q&A box that has a question mark in it. Please add your questions, but I'll get started. Can you kindly explain more on vertical and horizontal scale up?
Okay. So vertical scale up would be addressing the policy environment, for example. So how are different interventions reimbursed? And actually, a study that I'm on, we've explored this and seen if we could get our intervention listed as one of the preferred interventions in our Medicaid supported system. That kind of change would be vertical scale up.
Great, thank you. Another question, what did you find were the best and most effective ways to engage with relevant stakeholders? Word of mouth, social media, coordination with other programs?
So engagement would be a whole other presentation. It is such an important topic for us to address with, and each study is somewhat different. I would say starting with some kind of a planning group, a coalition, or some group that can advise you and help link you to key decision makers who are the folks who make the decision to adopt an intervention, to get an understanding of who to reach out to. I would say relationships are perhaps one of the most important active ingredients in scale up, is developing strong, trusting make sure you are a trusted partner and work your networks, your social networks.
Yeah, and we have a couple more questions, but just pushing on this one a little bit because we do have time. Thank you for leaving time for
Okay,
discussion. No, it's great. When you're starting out, and this sort of goes into a question that I have. So when you're starting out, can you say a little bit about understanding what the thing is that you're implementing and how that relates to the different levels of engagement that you might require?
Oh, that's a really great question. And is who you need to engage will depend on where you are in developing the thing that you're trying to implement. And so early on, you're developing the intervention. And so I think the folks who are intended to benefit from that intervention are very important, as well as the folks who are intended to deliver that intervention. As you move more towards scale up, the decision makers for adopting an intervention become increasingly important, and the networks that those decision makers belong to, whether professional organizations or others, where you are more important to engage. I don't know if that answered your question.
Yeah, I think so. And I'm going to jump other questions, but just because this is in line with our conversation here, to a question. And this one says, thank you for your insightful talk. When you talk about two levels of implementation, delivery and support, I'm immediately reminded of two levels we implementation researchers often use to describe complex interventions themselves. And that is functions and forms.
Oh,
Do you think there might be a meaningful parallel here? That is, support systems deal with functions, delivery systems deal with forms, question mark.
so I'm a big fan of forms and functions, first of all. But I would caution against the parallel in that way. I would say forms and functions are relevant to both levels of implementation strategies that you want to. So capacity building strategies, which is not the only thing that support systems can do, but was the focus of my presentation. The function may be to educate, to build skills, to provide an opportunity to practice skills. And those would be the functions. The forms could take many different forms, and it's similar at the delivery system level.
Right. And for those of you who may be new to that form and function language, the function is sort of the mechanism of action, why something works, right? And the form is how that's operationalized in a way that makes sense for the particular setting. So totally agree with your response, Jennifer, that forms and functions are components of implementation strategies at any level. So at any level that you're intervening with an implementation strategy, there will be a form and function of that implementation strategy. Embedded kind of within this question, and this is where we'd be getting into I think a debate, and want to avoid that, but just to put it out there, there's multi-level interventions, and then there's the strategies that we use to deliver multi-level interventions. Do you ever sort of get
this comes up all the time.
Yeah.
This is such a, and you may disagree with me, and I certainly welcome that. But I think you just have to put your stake in the ground as to what your intervention is. And there is no hard and fast rule of what's an implementation strategy versus what's part of an intervention.
Yeah, thank you. Yeah, and I totally agree with that. It's just defining what the thing is, and then what you're going to call the stuff you do to help.
And I just want to make sure the thing in implementation is the intervention. In scale up, I make the case that the thing is both the intervention and the implementation strategies that you're now trying to scale up. So I just want to take a chance to reiterate that.
Really important point. There's another question. Let's see. Is implementation science also being applied in the human services sector? And is there a body of research in that area?
Yes. Yes, that is not my area of specialization, but the systematic review I presented during the end included both health and human services studies in the systematic review.
Another question, sorry. What is the major implementation outcome associated with scaling up?
I don't know it. I mean, I think there's multiple that are important. I think adoption, how many settings actually adopt. I think this is a whole area that I because of time, but the extent to which we are evaluating and monitoring our scale up, once it goes to full scale, it's like you've set it free often. And that monitoring and evaluation after you do step 3 test, you kind of set it free. And I think we need to build in more monitoring at step 4. And what I would focus on is adoption and then some measure of fidelity. Is it because it's so easy to set it free and then to have people just, I mean, they need to make it their own, but they need to maintain fidelity to the core functions as well if they want to get the same outcomes.
Yeah, and I think that relates to this next comment / question by Anna Bergstrom. Thanks for this. I would also always start to understand the needs of the providers to develop strategies so that makes sense. Then giving it a name, well, it makes sense to name it something that makes sense to those involved and not start with Eric. But do you see that as valuable for the implementation science community to try to align it with what we call implementation strategies?
So that's a great question. And I always back translate. So I think as a field, we're trying to get a more consistent terminology so that we can aggregate what we learn. And so it's important to use the standardized terminology when you report out to the implementation science field. So I, use both. I'm bilingual. I try to be bilingual.
Yeah, and I know that often comes up when, for example, we're using implementation mapping to plan implementation strategies. We're often not selecting from the ERIC list, but we often sort of tie it back to the ERIC list to help build the science and and speak a common language, which it's very useful for. Let's see. Yes, we are going to be having the recording. Somebody asked about the recording. The recording is going to be on our website. Lizette, if you could just put a link to the website. And we've also asked to have the citations. I think the citations are now also in the website. Let's see. So we probably have room for a couple more questions. One of them, there's someone who says, I'm very new to implementation science and have heard many different definitions from many people. I'm wondering, how do you personally define implementation science and its purpose?
So how do we get people to use the interventions that we know work? So what are the strategies that we can use to get people to adopt those interventions that have an evidence base, to implement them as intended and to sustain them over time? Is the science of figuring that out. People have much neater definitions than that.
At what point is sustainability measured?
I think you can start considering sustainability very early on. And there's sustainability, which to me is, are you putting into place what needs to be put in place for this to be sustained? And then there's the objective, was it sustained, and measuring that. And you really can't measure whether it was sustained until after active implementation. and moving on. But I think you can, during implementation, start to look at whether, and we are currently doing this in one of the studies I just mentioned, the one that's ongoing, and using the clinical sustainability assessment tool during active implementation getting towards the end, but to look at whether the core domains that are identified in that tool are current, to what extent are they currently in place, and where do we need to work to put those things into place before we finish active implementation.
Right. Okay, we have a comment and question from one of our own students, Meryl Millett. So she says, "Hi, Jennifer. This is Meryl Millett. Great to see you, and thank you for a wonderful presentation. I love the way you presented using the priorities and frameworks of the practice and implementation studies rather than imposing our own academic frameworks. I'm wondering if you can expand on more pragmatic approaches to implementation research."
So we do have, one of the articles that I put up a screen on is a 5-step approach that attempts to be more pragmatic, partly to move more quickly through the formative stages by building on what's already known, including building on what your practice partners already know, and building on your practice partners' change methods as a way of being more pragmatic than we sometimes are with our extended formative work. That's, and good to hear from.
And then we have a question from Jorge Cruz Science, who says, "Has UT Health Houston considered a recent legislative bills and upcoming 90th legislative session funding opportunities in the correlation with upcoming transformations that will result to address rural health programs?" And this is a broad question because all of our states will be receiving, hopefully, funding for rural health transformation. And the answer to UT Health is yes. I was actually in Austin yesterday at the hearing. I think that there's a tremendous role for implementation science in trying to transform rural health. There's specific wording in the program about using what works, which was what Dr. Leeman helped define. What is implementation science? Is trying to study and understand and accelerate and improve what works. So yes, absolutely. And then
can I just build on that?
Yes, absolutely.
Because that's a great example of vertical scale up, as an opportunity to, and it's so great that you're going to be fully engaged both with the design of policies like that, but also with the how they are implemented and put into practice, is an opportunity to build an environment that's more supportive of the interventions that we want to see.
Thank you.
To scale.
Thank you. And then the last question I see here is, what tools, resources are available to have a better understanding about implementation science? We definitely have many phenomenal talks on our website, as well as training opportunities, short courses and the like. And then other universities, including University of North Carolina and others, have resources and training available. I don't know, Jennifer, if you want to say anything else about that.
Yeah, there are lots of resources out there. And I mean, I could name, I think you should stick to advocating your university. Our university has the ImpSci Exchange, which includes links to different resources for learning more. I know the University of Washington has an excellent site that includes links to resources for learning more.
Yes, and Washington University.
And Washington University,
also,
absolutely.
and many others. So there isn't a lack of that. All right. Well, thank you so very much, Lizette. Any final words before we close up here?
No, just those who are getting test credits, you'll be getting an email in the following week to do your eval.
Thank you
so much.
Thank you, everyone, for joining, and thank you so much, Dr. Leeman, for a phenomenal presentation and discussion.
Thanks.
Bye, everybody.